All right, welcome back. This is my last lecture to share with you in this session. We're back in that book, Gynecologic Healthcare: Alterations in Sexual Functioning. The book gives somewhat of a dry discussion of it. I'll try to add a little bit of my experience in clinical practice, which hopefully will help you in your clinical practice as well. Let's get started. So first of all, what is sexual dysfunction? What is sexual dysfunction? In fact, the chapter is titled Alterations in Sexual Function. So what is dysfunction? Part of the understand that sexual functioning varies widely among women for various reasons. There is not a normal sexual expression necessarily, whether it's sexual engagement in sexual activity, number of times of sex. There's how women view it is very wide experience. And there are many different definitions of sexual dysfunction that are inconsistent. In general, there are problems of desire, arousal, and orgasm, as well as sexual pain disorders. It's really a problem when the woman feels it's a problem and has some distress by it. That's really where it crosses over that line into dysfunction. There has to be some significance of distress. So one woman may come in and be distressed. I've had patients like this in my practice. I'm distressed that I'm not interested in sex daily with my husband or with my partner. There may be another woman and her husband partner, they have sex once a month and she's very satisfied and happy with that. She has no distress about that at all. So one, sex every other day, but not every day, is distressed about it. And the other, sex infrequently, comparatively, and not distressed. So no real issue. If we look at these definitions, and they've over the years have changed and morphed definitions. Here are some kind of generally where we sit. We look at desire, arousal, orgasmic, and sexual pain dysfunctions. You see over there on the left, the DSM-5. There's a DSM-5R now, but basically categorize this as female sexual interest arousal disorder, put that into one disorder, female orgasmic disorder, and then a pain disorder. We'll skip this because this really focuses just on vulvar issues. So it talks about vulvar pain and vulvodynia. 2016, the International Society for the Study of Women's Sexual Health, hypoactive sexual disorder, female arousal disorder, persistent arousal disorder, orgasmic disorder, organic illness disorder. So you'll see different. You may hear different terms. You may read about them in different textbooks. Usually they're going to use the DSM-5R terminology, but they're going to cluster around these areas: desire, arousal, orgasm, and then pain. And that's a good way to think about it. It's very prevalent in a practice where you're asking about this and investigating, and people have a relationship where they can talk to you about it. You're going to find this quite a lot. Here's one study where 44% of women reported some type of sexual dysfunction over their lifetime. So it's a fair amount. And of course, for many women, it's not sexual dysfunction forever. It's at periods of time, whether it's pregnancy related, postpartum related, relationship related, menopause related. There'll be times where this happens. And if we look at where it really clusters around, desire is the most common sexual dysfunction. Low desire, sometimes termed libido, low arousal, and orgasmic difficulties are less still. And again, let's just even talk about desire to start with, since it's the most common. We'll talk about it in a second. Typically, there's not a lot of issue with a woman if there's not a mismatch. So desire, if it's similar, her desire is similar to her partner's desire, there's a match, there's usually satisfaction. If they are at different places, there can be discord and dissatisfaction. So it's related to lots of things. Like I said, it's going to be related to lots of things in a woman's life. It could be health related. The book makes a lot about health related sexual dysfunction, and there certainly is some, absolutely, and we'll talk about it. I think it's the minority of the reasons or causations. Certainly partner/relationship factors. We'll just start with partner. So some of it may be the partner's having health problems, and that's probably more common when you look at menopausal women in their, or perimenopausal women in their late 40s, early 50s, 60s. Their partners, male partners, are going to be in that same age range and probably have male sexual dysfunction, like erectile dysfunction, which is difficult. May not be hers at all, but she's a part of the relationship. Relationship factors, I'm going to come back to a couple times because I think this is one of the key factors that drives desire disorders, and your book doesn't really delve into it a lot. Social cultural influences, that's very true. A person's experience and thoughts about this, whether there could be relationship dynamics, performance dynamics, pregnancy dynamics, cultural shame around sex, expressions of sex can certainly interface with that. I'll also put social cultural, really just the busyness of life and less family time and work-life balance that is undone can really interfere with this as well. So how would you in general look at this? Well, as we would joke, the answer to this always is take a complete history and physical. Yes. So we do want to do a physical exam. We want to do a psychosocial history and assess sexual health. We're going to give you a questionnaire suggestion here in a second. Identify chronic illnesses, medications. Medications can be, cause is a strong word. Cause is a strong word. Exacerbate, associated with, certainly can be. To me, for me to really believe this is causing it, a woman would have to come in and tell me, let's look at combined estrogen, progesterone contraceptives, right? Okay, so why are you giving a medication that causes sexual dysfunction? Well, it doesn't really cause it. Now, I believe this is true in some women. The vast majority of women, this does not affect sexual functioning at all, right? Doesn't affect them at all. There are women who say, I had no issues before the pill. Nothing in my life has changed except the pill. I've been on the pill. My desire went from 7 to 0. I decided to stop the pill because I didn't like it, and we went back to condoms, and my desire is back at a 7. Okay, I think for that woman, that's a very compelling argument. That doesn't let me tell the next woman who wants birth control pills, oh, this could cause sexual dysfunctioning, because I see it maybe 1 in 200, 300 women would have that type of interaction. And look at some of these. Gonadotropin, dang, come on, Matthew. Gonadotropin releasing hormone. Well, why is somebody on that? Well, there's reasons for this. They probably have, especially if they're younger, they have fibroids or they have endometriosis, other things that are going to add to it as well. Hormonal therapy. Yeah, why are we taking it? Probably because you have a hormone deficiency, pain issues, mental illness, substance abuse affecting relationships likely. So there's a lot of comorbid issues going on here. So yes, these can be related to near adjacent female sexual dysfunction. There are very few things that tell me, oh, that causes it. If you take this, you will have sexual dysfunction. I will say antidepressants is a little bit higher on that list. I see a little bit more with that, but again, comorbid with the psychological state as well. So again, talking about where is their psychological state, what mental health issues are there. There is a way to talk about, how do we ask? Do we say, how's your sex life? Are you happy? What do we ask? Here's a good way some good questions, some open-ended questions to begin that conversation. Do you have any sexual concerns or problems you would like to discuss? Great open-ended question. It's not saying you do or you don't. And would you like to discuss them, knowing that you're open? And these are just concerns. You don't say, are you having sex problems? Well, it's not that bad. No, I just want to have a discussion. I want to ask some questions. That's why this first question is very nice. And I certainly would put this into your normal primary care, preventative medicine visit with women and men, but certainly we're talking about women. Do you have any sexual concerns or problems you'd like to discuss? Very open-ended. And what are you experiencing? Which of these concerns are you experiencing? How does this affect your relationship, your life? How is it impacting you? What's the most distressing part? What treatments have you used? And then what do you think is the source of your sexual concerns? These are great list of questions, and I think very adequate to get you going with the discussion. We're going to talk about these desire, arousal, orgasmic, and pain dysfunctions. Certainly they can overlap, not uncommon. A good example is desire, libido issues, and pain. If something hurts me, I don't want to do it. That makes pretty sense, you know. If my foot hurts and when I run, I don't want to run. Do I have a running desire problem? Not really. It's a rational response to the pain I have in my foot. But yes, and if I have low desire with sexual issues, is arousal likely to happen? Probably not. So these do overlap in many cases, and a lot of it is pain generated, kind of takes care of all of them, kind of overlaps everything. So I agree with this statement here. Determine whether it is psychological, physical, or a combination. And many times it is all of the above. It is all of the above. Back to my example. If a woman has pain with sex, is it a psychological problem that she has low desire for intercourse? Probably not a psychological problem. That's a rational approach. But we do have to understand there's that overlay of a psychological part within the physical. They're deeply connected, especially in desire and arousal. Let's start with this combined, and they combine them, but then in the text they split them up. So we'll start with sexual interest and then go to arousal and kind of treat them somewhat differently. There is a very specific, just if you're familiar with the DSM-5R, which you probably are, if you're going to use that, there's a specific number of characteristics. Do we have to do that? I don't actually think so. To discuss and use this sexual interest or desire disorder, if you want to make that DSM-5R diagnosis, you would need 3 of the following 6. I'm not going to read through them. They're here on the slide. I think any of these are enough to talk about. And again, she needs to have some distress that kind of drives this dysfunction and drives her desire to do something about it. So let's start with sexual interest here. How long has this been going on? Have you always felt this way, or something changed? Has something changed? And when did it change? What happened? Certainly asking questions about abuse, current partner, conflicts in the relationship. Asking about frequency of sexual activity is helpful, although it doesn't necessarily, again, tell us a lot, except unless there's a change in frequency, because frequency itself is not a marker. There's no median, there's no normal. It's, again, what is her expectation? I'm gonna put a little star by this next section, which I think your textbook treats very small amount of text to this, gives very small amount of text to this. But this is about sexual satisfaction and satisfaction in relationship. This is in the context of married heterosexual couples. I think it's more than that. I think this does get at that normal sexual, I would say normal, that basic understood sexual response in women is typically both physical and psychological / emotional. There's a connection there. More so, and I'll put in contradistinction, to men. And you'll probably have another lecture at some other point about sexual dysfunction in men, which is mostly erectile dysfunction, not exclusively, but mostly. And that has lots of different inputs from psychological to physical as well. But it is mostly the erectile dysfunction in men is mostly the function of physiology and blood flow, typically. Women, it's more complicated. As the higher order of the species, they're more complicated, and there is more of a connection between the physical and the emotional, psychological. So in most physiologic descriptions of sexual arousal and interest, what drives for most women, at least there's a connection for most, not all, this is not a blanket statement, is an emotional connectedness, safety, relationship, romance. These are all synonyms for a connectedness to partner, safety and connectedness to partner. And until that is felt, desire does not begin. And until desire is there, arousal doesn't typically happen. So typically, if there's an arousal or desire issue, we're looking back to not that there's a relationship problem, but is there that closeness, that connectedness beforehand that has to happen. So a common explanation I'll give to my patients, and again, this is where I'm going off script from the textbook here. A common description I'll give to my patient is, no, I'm not saying anything's wrong, but for your typical couple with a couple kids, she's 35, they have 2 kids in elementary school, and they're busy with social and work life. Initiation and interest in sex is something like, it's Tuesday night, it's time to go to bed, do you want to have sex? The guy asks. She's like, well, I've talked to you for all of about 5 minutes today. And he's like, okay, so what does that mean? Again, getting back at the physical and psychological preparation that women typically will have in their normal physiologic response versus men. And so having her understand that and acknowledge it, and most women say, yep, I understand what you're saying. And usually it's more time and more connectedness prior to intercourse drives that desire, drives in that arousal. Another way to kind of give an example of the difference between men and women and what drives some of this sexual arousal issues. Let's say the couple, man and woman, are both ready to have sex, but they have an argument. Physiologically, can the male typically have sex? Yes. Physiologically, can the female typically have sex? No, typically. That's just to show there is this linkage between these. It's not, I'm not saying in all cases all the time, but there is a linkage. And I would say the vast majority of women expressing issues with sexual dissatisfaction, it's arousal. And for most of those women, it has to do with increasing emotional connectedness in their relationship, usually, which for most people in our modern society equates to time. I would hand out these newsletters from a sex therapist in my office that basically had the sex therapy was make a date, make a plan, have more romance, have more time. Those are your 5 main ways to, and then they talk about clitoral stimulation and correct anatomy, absolutely. But most of it was have more time, have more romance, have more dates, have more basic time set aside for the couple. Okay. Are there physical symptoms? So we talked about the relationship. That's helpful, and that's where most of your help is going to be. What about menopause? Menopause is a time of lots of physiological changes. There's going to be hormone deficiencies. You're going to have vaginal atrophy. This is a great time to use estrogen topically, as we talked about with menopause last time or 2 times ago. This is a great use of topical estrogen as needed, but maybe once or twice a week can help and really improve things. Normal alterations in desire. There is an aging process. Longer duration of a relationship. This is where, again, back to some of these ideas of where this couple's in a rut. They have routines. Sex has become just what happens after the news on Thursday nights. and really having that emotional connectedness can really change things. At times, counseling is needed. I would say for the vast majority of patients I talk to, the discussion we just had would help them a great deal. A few would need individual or couples counseling, and certainly if there are bigger traumas to get over, significant relationship issues, domestic abuse, sexual abuse, those are difficult and need counseling for the woman to navigate for sure. All right, we talked about menopause. Oh, the book does say there is no clear consensus on the usefulness of androgen testing and replacement in women. You'll find a lot of I'll just say snake oil where people are being tested for X, Y, and Z and being replaced. There's not a lot of good evidence about androgen deficiency. Again, this is for the vast majority of women. There's probably not a role in a general women's health clinic for androgen testing. This could be in the sex therapist's office, that small, minute group of women who've tried everything else, perhaps. Vast majority are going to respond to what we've been talking about here. I would say back to couples or sexual counseling. Couples counseling is helpful, especially when the sexual dysfunction appears to be distressing within the relationship. So it's making the relationship more difficult. So the couples counseling may help that togetherness. If it's a particular issue, cognitive behavioral therapy within the individual, that may help. And then if it's a more significant issue around sexual abuse or cultural understanding or particular sexual activities that the couple's having a difficult time with, a sexual therapist might actually help. The book does go into a great deal of treatment, good discussion about philibanserin, which was approved. I think I've never used it. I have a hard time saying it. Vyleesi, which is an injectable, FDA-approved hypoactive sexual disorder. Never used it. Never seen a need for it. Is there a use for it in certain circumstances and specialized offerings? Perhaps. I think in a general primary care, women's health, I don't think giving it would be the best idea. As far as SSRIs, I think watch out for SSRIs as having side effects for sexual depression of sexual arousal. Yes, and you may want to change those if a woman is feeling that. Estrogen, orally, topic, transdermally, maybe. Certainly for the woman who has genital urinary atrophy, I think that is helpful, and it certainly can be helpful, especially when she feels an arousal issue there. Okay, let's talk about sexual arousal disorders. That's an absence or impaired genital sexual arousal due to physiologic conditions. Kind of, yes. Remember, though, we talked about if there's really no desire usually precedes arousal. If there's no desire, usually you're going upstream. Now, can there be desire and no arousal or limited arousal? Absolutely. And you want to look for those physiological issues. Some of it is vascular, right? Diabetes, hypertension, coronary artery disease. The same problems that are in the arteries there are in the arteries in the genital tract. Physical activities like bike riding, horseback riding, motorcycle riding, when there's a lot of compression, that could be a problem. Certainly any kind of infection, skin condition there. So you certainly want to do a thorough exam. And whatever you see, you're going to treat. Lichen sclerosis, vaginitis, absolutely treat those things. And that may make it better. Sometimes it is a misunderstanding of the normal anatomy and the sexual response. So again, that newsletter I would give out from a sex therapist had kind of a man's guide to pleasuring a woman, is what it was titled. And it kind of went through clitoral stimulation, understanding where the clitoris is, how to achieve adequate clitoral stimulation. Sometimes there is a dryness and there is a circular a circular problem. So stay with me here, and we'll come back to it with the pain syndromes. But a common time to have low lubrication in the vagina is postpartum, and there may be some fear after postpartum. So a woman's got fear and a little less lubrication, attempts intercourse. Her mind is not actually there because she's worried about babies. So maybe there's not that connectedness right now. So she has multiple things working against her, and there's intercourse, and it's somewhat painful, which what does that lead to? More fear, less lubrication, less connectedness, more pain. You can get into this cycle. So sometimes, especially postpartum, this is a great time to say, anticipate it, help her anticipate it, help her anticipate this barrier, and say lubrication is a great answer right here. Because right now, what you don't want to do is get her into that vicious circle of low lubrication, more pain, less interest, less lubrication, more pain, and you see how it goes. So lubrication can be helpful, at least until she gets through that postpartum time. This can also be helpful at menopause. At menopause, estrogen's helping, but lubrication, a little lubrication may be all that's needed. There can be some medications. I don't, again, in the setting of a primary care women's health clinic, I think is probably beyond the scope. I've never given any of these medications in my practice as a gynecologist. Perhaps a pelvic floor clinic with that really small subset of people, perhaps. Yeah, and certainly smoking and alcohol can affect it. Is just stopping smoking and alcohol use going to make everything better? Probably not. It could be a contributor to it, and it's certainly a good time to encourage a woman to do it. I wouldn't promise her that that's the only issue. You're smoking and drinking. If you stop that, everything will be better. Probably not. It's certainly a good health benefit, though. Vaginal lubricants, estrogen, complementary and alternative therapies. The book talks about it. Again, is that what you're going to reach for right away with your primary care clinic? Probably not. I think vaginal lubricants, estrogen therapy is probably right in your wheelhouse. Female orgasmic disorder. Now, this is a delay, an infrequency of, or absence of orgasm or reduced intensity that lasts for 6 or more months. So part of it is the questioning about which one of those it is, right? Is it absence of, never have had an orgasm, they're less infrequent, or there's a delay? Back to the stimulation. Is there correct stimulation? Do women understand the anatomy, where the clitoris is? And not just does she understand it, does her partner understand it? One of the reasons I like giving out that newsletter from our sex therapist that put together is that it's something tangible she could take home, because sometimes these discussions that you may have with the woman are hard to connect back to the partner. Maybe one of the reasons they're having strife is they have a hard time talking about it. This is a difficult subject sometimes, very emotionally and ego connected. So sometimes handing this to him, leaving it around, leaving it so he can read it, is a helpful way to communicate. Obviously, you would prefer clear communication, but that's not always the reality. I would usually tell the woman, tell your husband, tell your partner, Dr. Lee gave him some homework. Here it is. You can hand it to him, and it's on him to read it. But it's a good way to help begin the communication. There are some FDA-approved medications for arousal and orgasmic dysfunction in women. I'm sorry, I misspoke. There are no medications, FDA medications for this. This one is a good bit more difficult. This is a good, this is a treatment that's very ripe, a plan that'd be very ripe for sex therapy. So for the woman who has never had an orgasm, who has significant orgasmic issues, and it's very distressing, I really feel as women's health providers, me and you, we don't have a lot to offer. I think sex therapy is a good role for this. There's not a lot of medications. There's not a lot of education in that setting. that we're going to do in a short office visit. I think having a relationship with a sex therapist like I've had for many years is helpful, and knowing how to get this woman help. This one is the harder one to deal with. I think desire, arousal, much more common, much more easily dealt with. Orgasmic disorder, less common, and especially severe. This is a good role for sex therapy. Obviously, if there's some cause, we would treat that. But again, if there's really no overt cause, this is a difficult one, and sex therapist is helpful. All right, let's talk about pain. Pain. So start with this term dyspareunia. I need to know this term, dyspareunia, which is painful intercourse. Pain with intercourse. And yes, it's helpful to determine the location of the pain. I would add in, and your book doesn't highlight it very well, but I would add in right from the beginning, in part of your history, is this penetration pain, external vaginal penetration pain, or is this, no, there's no pain there, it's deep or insertional pain? Those, I'm thinking of two very, very different disease processes. And your book makes short work of that. It doesn't really talk about it. It kind of talks about deep pain more at the end, like it's really all insertional and there's some deep pain. No, I'd say it's about half and half, honestly, half and half. And again, these can overlap each other, and we'll talk about why. Let's work backwards and talk about deep pain for a second. So why would you have deep pain? Typically, this is pelvic dysfunction. So it's either pelvic muscles, the uterus itself, endometriosis, the uterus moving, the cervix moving. That's probably the most common in a reproductive age group. It could be adenomyosis of the uterus, painful uterus itself. And you're going to find this on pelvic exam. But you're tipped off because she says it's only deep penetration. That's when it's painful. In fact, when different positions, maybe she's on top and can control the speed and depth of penetration, she doesn't have as much pain. I'm starting to think that's deeper inside. I'm thinking her uterosacral ligaments. I'm thinking her uterus. I'm thinking pelvic inflammatory disease. I'm thinking something in the pelvis that is of interest to investigate. And what else is in the pelvis, right? We're not going to forget about the GI tract. So that could be IBS. We're not going to forget about the bladder. That could be painful bladder syndrome or interstitial cystitis. So depending on what I find on exam, we may need to begin to work that up. That may be a laparoscopy. That may be a cystoscopy. That may be a colonoscopy, especially with the deep and not just on entry, penetrate. Maybe I didn't use the best words, but entry and deep penetration is what I'm really trying to say. Initial penetration or deep. So the rest of the book really talks about this external. And obviously it can come from lots of, right, if there's any problem externally, herpes, trichomonas, bacterial vaginosis, sure, absolutely, lichen sclerosis. I'm going to assume you're going to see that. One of the common reasons for that insertional or pain on just initial penetration is the term vaginismus. And your text doesn't talk about it well, but I'm just going to introduce that term here. Vaginismus is an involuntary contraction of the pelvic muscles during attempted vaginal intercourse. There's a typo here. We'll fix it in a minute. Vaginal intercourse. That could be for a variety of reasons. Sometimes it's because of the deep pain. So the example I usually give in class is I tell the story of my two boys. They were at home. They were teenagers. One was 16, one was 13. So if you have teenage boys or been around teenage boys, what happened when the 16-year-old walked by the 13-year-old in the house? They're boys. He would punch him in the arm. Punch him in the arm. Why would he do that? Because they're boys. I don't know. What would my 13-year-old do then as he got closer to his brother? What would happen to his arm? Because he knows the punch is coming. He would tense that arm up so it didn't hurt as much. Would he do it voluntarily? It may be involuntary. He may even flinch. Even if the one brother just pretended to punch, he would flinch, right? So that's a normal response. So when there's pain deep in the pelvis on intercourse, what happens when intercourse is beginning and getting ready to happen? There's that involuntary contraction of the muscle, which makes it more pain. So it can seem like external pain, and it may seem vaginal wall or vaginal muscle pain as you're palpating and feeling, but it also may be deep pain that's beginning that. Vulvodynia just talks about recurrent vulvar pain without any clear identifiable cause. So we don't say vulvodynia because she had herpes. No, that's just herpes pain. This is no problems that we can identify, but there's pain usually when we touch in an area, and that needs to be identified. We'll try to treat these areas individually as we can. So how would we treat? Treat whatever you find. Obviously, if there's infections, yes. If there's a dermatologic disease disorder like lichen sclerosis, we can treat with corticosteroids. Probably going to treat with pelvic floor physical therapy for that penetration pelvic floor pain. You can use pelvic floor muscle desensitization, especially for that vaginismus. There may be physical therapy that kind of works those muscles and helps relax those muscles. Cognitive behavioral therapy, somewhat. Really, I'm thinking acupuncture. I don't think so at all. That's what your book says, but I don't think that's really helpful. Maybe as a last resort, but there's usually other treatments. For that deep pain, that penetrating pain you feel on exam, you feel the cervix, you move the cervix and there's pain. You touch the uterus and it's pain. This person needs a gynecologist who's going to evaluate for pelvic pathology, maybe a scope, maybe a colonoscopy, maybe a bladder scope, all of these things. We do want to have a therapist, a sex therapist available. If you're going to see lots of women, you need to find a referral pattern for a sexual therapist. Who am I going to refer? Long-standing dysfunction. Yep, a woman comes in my office and says, for the past 20 years, I've had sexual pain, arousal issues. Boy, I'm not sure I'm going to fix that. I think maybe a specialist may be the next step. Multiple dysfunctions, abuse, a big one, abuse. I don't have the resources or training to counsel with her through abuse. Ongoing psychological issues, nope. Dysfunction that does not respond to therapy, depends. I'd question my diagnosis. Maybe I would send that person to a gynecologist. Some of these other, you probably just need to send to a sex therapist. Who are sex therapists? I've used that word a couple times. These are mental health professionals with real specialized training in psychotherapy for sexual problems. Kind of blended with this word sexual counselors a little bit. Some people may have an interest in it. That's maybe all they do. The person I referred to, their practice was exclusively sex therapy in the whole gamut of sex therapy. And it was helpful to have. In fact, I had those handouts that she had given me. I would give away probably 50 of those handouts for every one patient I saw, I sent to her, because a vast number of people needed just some education that we could give there in the office. So I don't want you to think I can't deal with it at all, and I can't give any help. People need sex therapists. I think very few people need sex therapists. They need some good sexual education that we can provide in the office setting about the topics that we just discussed. Certainly, if there's pain, we have to evaluate the reason for pain. I would say the vast number of people that I saw with pain on deep penetration had some type of physiologic issue with endometriosis, infection, etc. Two very good APGO videos. I've been sharing these APGO videos with you. I hope you find they're helpful. These are both very good, and I think very state-of-the-art, up-to-date, good, well-done videos. The first one's about 12 minutes, and it's really that, as we discussed, talking about sexuality. And the last one is for the treatment of sexual dysfunction in the different buckets of desire, arousal, orgasm, and pain. That's how you think through them. We talked about different strategies to diagnose, to treat, especially in the setting of primary women's care. I think it's where you'll be. All right. Hope you've enjoyed this lecture series. I've enjoyed giving it. This would be my last one for this group. Reach out if you have any questions, and be sure to check out some of these videos. I think they are helpful for your ongoing practice. Thank you.